We are so pleased to have Chris Jones, captain in the U.S. Public Health Service and the director of the Center for Substance Abuse Prevention, CSAP. Captain Jones brings a wealth of experience to SAMHSA, having led substance use, mental health, and injury and violence prevention policy, program, and research activities for more than a decade. Prior to becoming director of CSAP, Captain Jones served as the director of the National Center for Injury Prevention and Control at the Center for Disease Control and Prevention. In this role, he provided scientific leadership and overall management of the center, including driving the center's strategic direction and advancing the center's priorities of preventing drug overdose, suicide, and adverse child experiences. At CDC, Captain Jones previously served as Deputy Director of the Injury Center and as Associate Director for Strategy and Innovation. Please welcome Captain Jones.
Great. Thank you so much, Jamie, for the introduction, and thank you to ONTCP, HIDA, and ADAPT for the opportunity to be here today. I think we are at such a critical point in time, certainly underscored by Dr. Gupta's remarks about the enormous opportunity that we have to advance prevention in our country. Today, I want to cover sort of an update on where we are with substance use in the nation, try to place the current context of today's drug environment and prevention work in that context, and really think about how we can continue to innovate and evolve our prevention work in an ever-changing and dynamic drug landscape. And then think about how we widen the lens on prevention to really make sure that we are addressing the full spectrum of risk and protective factors. And then provide some thoughts really around the need to continue to evaluate and build the evidence base. Never accepting that we already know all the things, but that we need to continue to learn and grow as a prevention field. So just stepping back a little bit, Dr. Gupta talked about some of the top line numbers for drug overdose deaths, but if we step back and look at the last 40 years or so, we really do find ourselves in unprecedented territory. And while the particular drugs that have been driving overdose deaths in the US have changed over time, we really have never seen the magnitude, scale, and scope of overdose deaths as we do now. And this is data through 2022, provisional data from CDC. And you can see that really over the last 30 years or so, there has been this exponential increase in overdose deaths. But in the last several years, in particular, during the first 2 years of the COVID pandemic, we saw really steep increases in overdose deaths, some moderation in 2022, as Dr. Gupta discussed as well. One thing that is important to note when we look at the national mortality data, and then we start looking at state level data, community level data, it's a more nuanced story. This is the latest data through April of 2023 from CDC's provisional mortality data. And you can see here overall at the national level, about a 1.7% increase in the number of overdose deaths in the 12 months ending April 2023 compared to the 12 months ending April 2022. But when you look at the states, you see a lot of variation. Some states are continuing to experience increases over this time. Those are the orange states. The sort of dark orange brown states are those with the highest or largest increases. And the states that are shaded in blue have experienced some decline over this time. So again, it is uneven, the patterns that we're seeing across the US. And a lot of this is a function of what's going on in the illicit drug market, the continued westward expansion of fentanyl, the eastward expansion of methamphetamine, and certainly the continued introduction of other substances like xylazine into illicit drug markets across the country. When we look at the particular drugs, again, synthetic opioids like illicit fentanyl are no doubt primary contributors to the increases in overdose deaths since about 2013. This is just looking at the past 5 years. We see less involvement for things like heroin, prescription opioids, and benzodiazepines. but increasing involvement for stimulants like cocaine and psychostimulants, which largely this category is capturing methamphetamine. But this is really a polysubstance issue. When we look at synthetic opioid involvement in overdoses that involve other substances, again, we see the majority of those deaths co-involve synthetic opioids. Whether you're looking at prescription opioids or benzodiazepines, cocaine or psychostimulants, synthetic opioids are a common denominator in those deaths. When we look at some of the demographic shifts that have happened over the last several years, I think the bottom line is that over the past 5 years, all groups have been impacted, increases really across the board, but some more than others. We see males having higher rates than females. When we look at age distribution, we tend to see young adults to middle-aged adults having the highest rates of overdose deaths. But even on the margins in younger and older populations, there have been generally increases over the last several years. One of the most important areas where we've seen significant shifts is around race ethnicity. So for many years, non-Hispanic white populations accounted for much of the mortality due to drug overdose. But really since about 2017, 2018, we've seen a shift for large increases among non-Hispanic Black populations and non-Hispanic American Indian Alaska Native populations, now having significantly higher rates of overdose deaths compared to non-Hispanic white populations or other race ethnicity groups. But again, you can see that all of race ethnicity breakdown here has experienced some increase in overdose deaths. But I think this equity piece is really important as we think about prevention, as we think about our work together to make sure that we are bringing affected populations to the table as we are working on solutions for those communities. When we look at urbanization, here again, we see across the board significant increases over the last 5 years, although slightly higher rates in more large urban areas. But the difference between rural areas and urban areas is not that large. And this is the last slide I wanted to talk about on the mortality piece. And I think it just underscores the sense of urgency and the magnitude of the challenge that we're facing with drug overdose. So this is looking at 10-year age groups from the mortality data from CDC for 2022. It's provisional data. And I basically calculated among the reasons why people die, among their particular age group, what percent of those deaths are due to drug overdose. And we find among 15 to 24-year-olds, about 1 in 5 deaths from any cause are due to drug overdose. That goes up to almost 1 in 3 for 25 to 34-year-olds and 1 in 4 for 35 to 44-year-olds. And I think oftentimes people think about heart disease or cancer, and that's what most people die from. That's true in older populations. But what we see here is just the magnitude of impact to individuals, younger age individuals who are dying increasingly from drug overdose. And that's accounting for a large proportion of why people die in those particular age groups. So I hope this is really a call to action to say, this is not happening on the margins of society. This is in communities across our country, and we have to do all we can to reduce overdose deaths. But it's also important to not just focus on the overdose deaths, because they really do represent the tip of the iceberg. Those are certainly our North Star in wanting to prevent overdose, but many people are using substances in harmful ways that impact health, that impact mental health, that impact physical health, social and economic impacts. And many people are experiencing morbidity associated with substance use or harm associated with substance use well beyond mortality. So when we look at SAMHSA's National Survey on Drug Use and Health, we see about 21% of the population reported illicit drug use in the past year, and that's use of illicit drugs or misuse of prescription psychotherapeutics. And you can see here, marijuana by far the most common substance that people report using in the past year, followed by prescription pain reliever misuse, opioids essentially, hallucinogens, followed by other categories of illicit and prescription substances. It's also important to point out that there are many people who are also using tobacco or vaping products, as well as engaging in binge or heavy alcohol use. And you can see the numbers here on the slide. So substance use overall is prevalent among the population. When we look at substance use disorders, again, about 46 million people with a past year substance use disorder, and it largely cuts along similar lines as the patterns of overall substance use that we see, alcohol being the most common use disorder, drug use disorders overall, about 24 million people, marijuana being the most common, followed by pain reliever use disorder. And then you can see methamphetamine, prescription stimulants, cocaine, and heroin beyond that. So again, about 16% of the population met criteria for a past year substance use disorder. One of the other things that I think is important to point out as we think about prevention in particular and the context in which substance use is playing out in communities is that it is very much connected to what is going on with mental health in communities across our country. And among adults, we see that individuals who have any mental illness, as well as those who have serious mental illness in the past year, have significantly higher rates of substance use, regardless of how you cut the data, regardless of what substance you're looking at. The pattern is very consistent. And so as we think about prevention, we think about health promotion, well-being, resilience, and as we think about treatment, recovery supports, other strategies to reduce harm, we can't do this in a vacuum, right? We have to think about the mental health overlap among people who are using substances. And when we look at initiation, again, from a prevention standpoint, I think this is a really important data point. What are the substances and how many people are initiating use of these substances for the first time? You can see here alcohol, most commonly initiated substance among people 12 and older. Marijuana, second most common, prescription pain relievers, hallucinogens, and cigarettes, and then other substances fall after those. But again, it provides us some sense of, among those who are starting use of substances, what are the most common targets or substances that people may be using. And I think the prescription pain reliever item is particularly important because there has been a large focus on reducing opioid prescribing, improving pain management, use of non-opioid medications or non-medications for pain treatment. And we have seen this large decline in opioid prescribing, yet we continue to see that prescription pain relievers are the most commonly misused prescription medication overall, as well as among those who are initiating misuse. And I put this slide in because I think it's important as we think about prevention. This just looks at the proportion of people who initiated cigarette use, alcohol use, or marijuana use in the past year, and what's the breakdown by age group. And you can see here that 12 to 17-year-olds, who might be a very traditional target for primary prevention efforts, account for a large percent or a large number of people who are initiating substances. But in fact, across these three substances, people 18 to 25 account for more individuals who are initiating use for the first time of these substances. And so we don't want to stop our prevention efforts at high school age populations or younger. We know that there's also an opportunity and a key opportunity for prevention among young adults as well, as clearly delineated here in this slide. And so it does challenge us to think about, during this period of transition, people are moving out of their traditional home environment, being on their own in college, in other places where there's just a different structure and a dynamic. How do we apply prevention science to that population? And so I think it is an important data point for us to reflect on. I wanted to spend just a minute on methamphetamine. So lots of focus on illicit fentanyl, synthetic opioids, rightfully so. But we've also seen a substantial shift in what's going on with methamphetamine availability, use, and its connection to rising overdose deaths over the last decade. This has been a particular area of interest for research that I have done with collaborators across HHS. And we see that according to a variety of different data sources on the supply side, that we have historically high levels of availability of methamphetamine in the US. It's not sequestered into one geographic area. We really do see it throughout the country, including in the Northeast, which historically didn't have a large market for methamphetamine. But we also see relatively high purity, potency, and low cost for methamphetamine. And so as the supply side has shifted, as methamphetamine has become more available, we see that individuals are increasingly reporting use of methamphetamine. This is from the National Survey on Drug Use and Health data over the last several years. Due to some COVID-related data collection challenges and some changes in methodology, we can't directly compare 2020 and 2021, but you can see even prior to COVID, there was an upward trajectory for past year methamphetamine use, past month use, and past year use disorder for methamphetamine, and that has largely, those numbers have stayed elevated in 2020 and 2021. We did an analysis of NISDA data a couple of years ago to try to understand, while the numbers of people who are using are going up, are the demographics shifting? Is this happening in one particular sector or one particular region of the country? And I think some key things that we found were that really the increases in methamphetamine use have been happening across most demographic groups. So it's not just one slice of our country. It's males and females, most age groups, most race ethnicity groups, most geographic areas. But we also found that people were increasingly using methamphetamine in more risky ways. So more frequent use, injection use, as well as meeting criteria for a use disorder. And this is from community data, essentially from the household survey. We also looked at this in the treatment data to see, do we see similar patterns? And we do. In fact, we found that treatment admissions for methamphetamine also increased over the same time period as the supply of methamphetamine was increasing. And we saw increases among most demographic groups, as you can see here on the slide. We also saw that this increase was largely driven by people who were shifting away from smoking and who were reporting injecting methamphetamine. And the other piece is that this is very much layered on to people who are also using opioids. So again, we see this shifting pattern, broad increases in use, higher risk use, very much connected to what's going on with illicit opioids. And we see that in the mortality data as well, that much of the increase where psychostimulants like methamphetamine involved in overdose deaths, we see that opioids, in particular synthetic opioids, are involved in the majority of those deaths as well. So because we are focusing on prevention, I did want to spend just a couple of minutes talking about youth substance use patterns, because we do see some positive findings related to youth substance use. This is from a paper I did with colleagues from CDC that came out a couple of months ago, looking at the Youth Risk Behavior Survey for 2021 data. And here we looked at the over the last decade trends for substance use among high school students in the US. And we see that generally patterns of substance use are going down across most substances. And that the majority of high school students do not report substance use. And I think those are like two key data points that are not often part of the conversation, and things that I think we need to raise up, that trends are going in the right direction, and that most young people are not using substances. And we see this again really across the board, whether it's lifetime use or current use of substances. In the YRBS, some questions have been added in more recent years, so we don't have as long of a time horizon to look at. But if you look at historical National Survey on Drug Use and Health data, or monitoring the future data, which looks at 8th, 10th, and 12th graders, we also see these generally consistent trends of a downward trajectory for youth substance use. But it is important to note that about 1/3 of students did report some form of current use of alcohol, marijuana, or prescription opioid misuse. And that among those who used, about 1/3 used 2 or more substances. So again, polysubstance is sort of the theme here, whether it's treatment data, mortality data, or use data. But within the overall data, while we do see this declining trend among youth substance use, it's important to note that we also see disparities in use rates among race, ethnicity, among gender, as well as among students who identify as LGBTQ. And overall, we see generally higher rates for most substances for females, a lot of variation when we look at race, ethnicity for the particular substances. And then really across the board, lesbian, gay, or bisexual students have higher rates of substance use across all substances. So again, as we think about prevention, as I mentioned with the mortality data, we really have to think about who are the populations that are being impacted, who is seeing some gains and reductions in use, who is being left behind, and how do we approach prevention in a holistic way to make sure that those populations are at the table, are part of the development of solutions in communities. The other interesting data point from YRBS is that while we do see sort of these positive trends on the substance use side of the ledger, mental health indicators among high school students have been getting worse over time. And you can see here, 42% of high school students reported feeling persistently sad or hopeless. About 1 in 5 seriously considered attempting suicide, 10% attempted suicide. So there's a clear disconnect with what's going on in the mental health side and the substance use side, but we know that they are related, and individuals who have mental health challenges have higher rates of substance use. But like the substance use data, we also see that the impacts are not evenly distributed among high school students, with females, lesbian, gay, bisexual students, and some race ethnicity groups experiencing far worse mental health than their counterparts in other sexual orientation, gender, or race ethnicity categories. And I highlight the mental health indicators among youth because as we see with adults, young people who are struggling with mental health issues, and in this case, this is looking at people who had a major depressive episode in the past year among 12 to 17-year-olds, have substantially higher rates of substance use regardless of how you cut it. So again, as we think about prevention, as we think about concerns around a mental health crisis among young people, this is not disconnected from the substance use challenges that young people are facing. The other challenge to all of this is that we are in a very dynamic situation. The illicit drug supply continues to change. Much of that is facilitated by the proliferation of fake counterfeit pills that look like commonly misused prescription drugs, but that contain highly toxic amounts of synthetic opioids like fentanyl, pressed pills of amphetamine or methamphetamine. And this causes significant unpredictability for people who are using substances. People don't know what substances they're using. They don't know the underlying source, how much of fentanyl might be in any of these products. And we also see the emergence of xylazine, synthetic benzodiazepines, synthetic cannabinoids, as well as synthetic stimulants that are also emerging into the illicit drug supply. Again, increasing unpredictability and toxicity in the illicit drug supply that people may be exposed to. And as Dr. Gupta mentioned, really, I think because of this unpredictable drug supply, using substances, whether it's the first time you've ever used a substance or you have a longstanding use disorder, it's never been riskier. And it really does challenge us to think about, from a prevention standpoint, how do we need to be thinking differently about our prevention work. We no doubt want to prevent initiation of substances in the first place, but how do we think about expanding access to naloxone in communities or in populations where historically maybe we didn't think that was even needed, like in school settings? So this toxicity and the high lethality of the illicit drug market really does present some unique challenges as we think about our prevention work moving forward. And I did want to highlight the mortality data among 12 to 17-year-olds because I showed the YRBS data and other data, again, that are consistent, showing that generally youth substance use has been going down. But when we look at mortality, we actually see significant increases in overdose deaths among young people. And again, this is a function of an unpredictable toxic drug supply, in particular counterfeit pills. That people don't know the substances that they're using. And we see again here, as with other age groups, synthetic opioids are involved in about 3/4 of the overdose deaths among people 12 to 17 years old. And that really is a primary contributor to mortality for this group. So it sort of reflects the disconnect between the overall trends, but also among people who are using substances. Substance use is very risky. And to me, it's really the call to action for why the prevention work is so important. If we can prevent people from initiating substance use or for progressing after they've initiated substance use, we have a real opportunity to reduce overdose deaths in addition to the many other benefits we know prevention can provide. So taking all of that data in context, what do we do? How do we think about our prevention work? I think the first thing is to really focus in on the spectrum of risk and protective factors. Sometimes prevention gets put in a box. It's a program that's done in high school. It is, something around raising public awareness, but as a standalone activity. And I think we have the opportunity really to define and redefine and revision what is prevention based on prevention science, based on our understanding of risk and protective factors, recognizing that we have to look at the individual risks within relationships, family, community, as well as societal factors that contribute. And focusing in on any one of these is necessary but not sufficient to produce optimal impact of our prevention efforts. But at an individual level, we look at genetics, early initiation of substance use, people who have low risk perceptions of use, peers who use substances, perception that use is common among peers, and then certainly underlying mental health challenges as an individual level risk factor. When we look at the relationship piece, thinking about parental attitudes, parental challenges like substance use or mental health, family conflict, emotional, physical, sexual abuse, neglect in the home, and then how are parents talking about substance use? What are their views on substance use? And then a lack of connectedness among families. Similarly, at the community level, are there opportunities for community connection and supports? What are community norms around substance use? Are people being exposed to violence in their schools or in their community? Are substances readily available in community? And then broader issues around poverty, lower socioeconomic status within the community. And then at a societal level, again, really broader concepts around educational and economic opportunities, inadequate housing, disinvestment in communities, discrimination. What are the social norms in communities? And then what is the law and policy environment in a particular community? And one of the areas that I think is a real opportunity, which if you look back at those risk and protective factors, you see that many of them can be defined as adverse childhood experiences or ACEs. The traditionally defined ACEs are physical, emotional, sexual abuse, physical, emotional neglect, household challenges like growing up in a home with mental health challenges or substance use, domestic violence in the home or intimate partner violence in the home, divorce or incarcerated relative. But we know that other experiences in childhood, like bullying, teen dating violence, witnessing violence in the community or school, and then issues of instability in a child's life can play out very similarly to the more traditionally defined ACEs. And ACEs are very common, and like we saw with some of the substance use data, the mental health data, the mortality data, certain populations are more burdened by ACEs than others. And ACEs produce their effects through toxic stress. And we know that those first few years of life are really a critical period for brain development, for how people will ultimately process emotions, how they will respond to rewards, coping strategies, cognitive function, executive functioning, weighing risks and benefits. And when somebody is exposed to repeated stressors in their life, we know that this stress can dysregulate these systems in the brain that are part of natural brain development and sort of developmental milestones. And I think it is important to point out that if you have experienced trauma or ACEs, you're not destined to have all of these negative outcomes. But we know that that can happen if steps are not taken to mitigate or blunt the effects of ACEs. And the reason that I raise ACEs and thinking about ACEs in the context of substance use risk and protective factors is that we see from the research that ACEs are strongly connected to risk for substance use. Again, however you cut it, we see a consistent relationship between exposure to ACEs, including number of ACEs, and risk for future substance use. And this, again, holds for prescription opioid misuse, illicit opioid use, stimulants, as well as other substances as delineated here. We also see that individuals who have experienced ACEs are more likely to initiate substance use at an earlier age, which we know is an important predictor for future substance use disorders. And like we see with substance use, we see a similar connection to ACEs and mental health. So again, these things are overlapping and interrelated. Thinking about risk and protective factors encompassing of ACEs is a real opportunity to get ahead of the challenges that we are facing. So as we think about risk and protective factors, as we think about the epidemiology, I think it's also important to really underscore that in prevention, we have science on our side. We have decades of prevention science research that demonstrate that prevention works. It is not some squishy thing, but that we can truly impact substance use, public health harms in communities. I wanted to highlight just a couple of studies that I think make this connection between risk and protective factors and positive outcomes. So this was a paper that was looking at people who've experienced ACEs, co-occurring psychological distress and substance use, and what factors were protective against those outcomes. And the protective factors reduced risk for psychological distress or substance use or both. And what they found were the protective factors were high internal resilience, so problem solving, life skills, self-efficacy, family communication, school connectedness, having a peer role model, and then having non-parental adult role models. So again, as we think about what we do in prevention, those are the things that we focus on, right? We want to help families communicate, parents and kids communicate. We want to create opportunities for connectedness, a sense of belonging, having peers who are positive role models, or that trusted coach, somebody from your church or synagogue, temple, somebody from your local YMCA, some other non-parental adult that consistently shows up and says, I care for you, you're an important person, can have very powerful protective effects. We see the same for poor physical and mental health, again, among people who have experienced ACEs. And this was looking at safe, stable, and nurturing environments. In this particular paper, even among people who have had multiple ACEs, if protective factors were present, it had a blunting effect on ACEs. So in this particular study, they identified an adult who made you feel safe and protected, an adult who made sure basic needs were met. So again, really thinking about how are we building beyond the individual those opportunities for protective factors in communities. We also see from early age programs that they can have long-term impacts. So this is really thinking about some of the broader policy or program pieces. And this is long-term impacts of a home visitation program, the nurse-family partnership. And what they did is they provided this program in the first couple of years of life for a woman who was pregnant. And then they engaged over the first couple of years after the child was born. And then they followed up 15 years later to look at outcomes for women who were in the program, as well as the children who were exposed to the intervention, and their parents were exposed to the intervention, but that stopped at the age of 2. And what they found is that there were broad positive effects for the women who were exposed to the nurse-family partnership or the home visitation program, but there were also long-term impacts on children who were exposed, and the intervention stopped at the age of 2. So again, thinking about very upstream prevention, how do we instill and ensure a strong start for families? Because we know that's an important piece of the prevention puzzle for protecting and reducing substance use and other high-risk behaviors later on down the line. So again, not sufficient to just do something when kids are in middle or high school. We really have to start long before, during those critical development periods, in addition to doing those things in middle and high school as well. So as we move through some of the prevention work, so thinking about early childhood, how are we helping families and kids have a strong start, but also recognizing that those middle and high school years are critical periods of development where people are sort of coming into their own and gaining some level of independence. We also know that those are really important times for initiation of substance use, influences of peers. So this is a randomized study looking at the Strengthening Families program in combination with life skills training that, again, looked at the long-term impact. So these were programs that were provided in 6th grade and 7th grade, and then they followed the kids up to age 19, and they found, again, really across the board, significant protective effects for substance use. And again, these programs are agnostic to substances, but they're really looking at life skills, problem solving, conflict resolution, helping instill resilience in kids, but they have these long-term protective effects. Again, underscoring the real power, potential power of prevention. And the other piece of this that I often like to talk about is that there can be long-term spillover effects for these types of interventions. So this was just a paper that came out a couple of years ago that looked at a multi-component intervention that involved teachers, kids, and parents. So trying to teach social emotional skill development for kids, but also helping to bolster parents, support parents in their work. And earlier studies of this intervention found that among the kids who were exposed to the intervention had reductions in substance use, mental health challenges, other risk behaviors. But then they went back and they studied the kids of those kids who were part of the original intervention. Their offspring were not exposed to this intervention, but they were kids of parents who were exposed to the intervention. But they continued to find, even in the next generation, positive impacts of the program. I mean, there's obviously a lot of challenges of other things that might have happened in these individuals' lives, but I do think it underscores the potential long-term impacts of prevention. Early investments in prevention have long-lasting protective effects. It's also important to think about, beyond programs, policies. So again, we know that disinvestment, lack of economic opportunities, housing, transportation, other disinvestment in communities, longstanding poverty are strong risk factors for substance use. So from a very big P policy perspective, how are we changing that environment to support positive impacts and protective factors and reducing risk factors? This is a recent study that came out looking at state earned income tax credits and its relationship to alcohol use among women with children. And they found that the more generous EITC benefits were associated with reductions in reports of chronic and episodic heavy alcohol use. So again, this is the idea that what are those stressors that play out in a home, right? Economic stressors, concerns about housing, how are you going to make ends meet, that can prompt substance use as a coping mechanism among individuals and certainly create stress within the family dynamic. So alleviating one piece of that stress via tax credit, alleviating some of the economic challenges shows a positive effect on alcohol use. So as we think about risk and protective factors, again, this constellation of individual, relationship, community, society, that is where we need to be going as a prevention field, taking into context challenges that are playing out at home, challenges that are playing out at school, broader challenges that are playing out in the community, thinking about social determinants of health, other longstanding impacts in communities as a broad public health approach to addressing prevention. And I sort of sum it up as really thinking about how do we build that tent in communities that is, one, using data to understand what is the problem, who is at risk, how is risk changing, where are we missing individuals in our community that could benefit from prevention, treatment, harm reduction, recovery support services. So data as a foundational piece to the prevention efforts in a community. Taking an equity lens, really centering the work in the voices and experiences of the communities that are being served. Again, we see changing demographics related to who is impacted by substance use. How are we bringing those communities to the table when we think about solutions? That we have to think comprehensively. We have to look at this not only at the individual level or the family level, but really at the community level, at the societal level. What are those dynamics that are playing out in communities that we can modify to lift people out of poverty, to support parents, to support schools, to really look across the lifespan? Where are those opportunities to address risk factors and strengthen protective factors? We do have an evidence base and prevention science on our side to inform this work, but we also recognize that we need to continue to innovate and build the evidence base. And there's practice-based evidence from what's happening in communities that we need to lift up, we need to evaluate, and we need to share that information as a prevention field to say what worked in this community, how might that work in my community? What do I need to do to adapt it? Some of the original prevention work is dated. It was done in certain populations that may need adaptation to other populations or a different dynamic with an illicit drug market that we're facing today, with the challenges of social media, with just other stressors that are playing out in communities. So we have a foundation, but we need to continue to build on that foundation. Part of that is broadening the tent of partners who are at the table. Again, thinking about who are the voices from our community that we need influencing and informing our work. And then the last thing I'll say is really checking assumptions. A lot of times when I've gone out and talked to folks about prevention, people are like, I know this works, it just feels right, but it's never been evaluated. So checking assumptions. Are we based on a strong theoretical basis? What are the risk and protective factors we're trying to address? What evaluation has been done? And then think about potential unintended consequences. Sometimes doing something that feels right can really be problematic. We see this in particular with communication campaigns, efforts to raise awareness among communities. We have seen massive failures of communication campaigns that were not formally tested, that were well-intentioned, but in fact caused harm. So as we are thinking about how do we develop messages that resonate, again, having those voices, having youth voices, having voices from the community, formatively testing, engaging with people who are communication experts are really critical steps to informing and making an impact with communications. But those messaging communication platforms and messaging campaigns also have to be attached to what's happening on the ground. We see that when there is a holistic approach to addressing prevention in communities, to helping raise awareness and then reinforcing the policies, programs, and practices that are happening and playing out in the community with messaging that we can have optimal impact. So I'm going to leave it there. I know we're a little bit behind trying to catch up to get back on schedule, but really thank you for the opportunity. Please know that at SAMHSA, we are continuing to innovate our programmatic work to account for all of the things that I've laid out here, a public health approach to prevention, and we want to be partners with you in this effort. We want to learn from you. We want to engage to help advance the prevention field. So please don't hesitate to reach out. It really takes an all-of-us approach to make the impact that we want to make. So thank you again. I'm happy to answer any questions.
Thank you, Captain Jones. Wow, I think we're all sitting here like, could he have said anything more important today after that presentation? We're looking at the chat and everything that you said is just so salient to the work that we do. Multiple people have written in and are just asking more and more questions about the data, and I can't get to all those. I'm sorry, guys, but we do have a few minutes to get to some of the kind of multi-level questions that will help maybe our audience understand the data a little bit better, more at that macro level. And one of those questions, Captain Jones, is this. You may have mentioned early on, but she's wondering, can you tell us what portion of the US population uses the substances identified compared to the problematic use portion? So any use of the substances compared to the problematic use. She's hoping to understand the spread of the substance use in the whole population a little better, and the spread among those using substances at all. So any use versus problematic use. Can you help us understand that better?
Sure. And I think, I mean, you know, problematic use is a little challenging to define because, you know, there can be harms associated with use, certainly before people meet criteria for a substance use disorder. And we don't always have good data sets to capture some of those harms. I mean, there are many health harms related to substance use. I think probably the best quantitative way to look at this is from the NISDA data, where we look at people who report past year illicit drug use as an example. So 61.2 million people reported using illicit drugs or misusing prescription psychotherapeutics in the past year, 61.2. When we look at people who met criteria for a substance use disorder, so in the NISDA, people who reported use, so, you know, that 61 million people were then asked questions about their use of those different substances that they reported using. So drug use disorders, it's about 24 million people of that 61 million. So about a third of people who reported use in the past year ultimately responded to questions that essentially capture the idea of problematic substance use or met sufficient criteria for a use disorder. Now that varies depending on the particular substance that you're looking at. Like for, say, marijuana use, you tend to see a smaller proportion of people who meet use disorder criteria compared to the overall number of people who report marijuana use in the past year. You look at something like methamphetamine and you see over half of people who reported methamphetamine use in the past year met criteria for a use disorder. I mean, that's not completely surprising based on just generally what we know about substance use patterns. So hopefully that answers at least some aspect of the question, that there are people who are using substances that don't meet criteria for use disorder. But I wouldn't want to say that they might not have harms related to their use, even if they're not meeting criteria for use disorder, especially with the illicit drug market that we're seeing, right? We definitely see cases where there are people who are very early on in substance use who got a pill from a friend who have no tolerance to opioids. They thought it was Xanax and they got, you know, fentanyl pressed pill and experienced an overdose. And so it's a very dynamic situation.
Thank you, Captain Jones. It certainly does answer the question and gives us a better understanding. We've had multiple questions come in on two specific subjects. Number one is both of them recognize that this is so important, that doubling down on prevention, right, is so important to address, as you described, the unpredictability and toxicity nature of some of the substances today. Understanding that, two particular themes are being asked about. Number one, buy-in. How can I get my school that I'm working in to buy into this, the importance of it? But then beyond that, how can I get money to fund something like you just described with the Strengthening Families and Botfin's life skills programs? If I want to do this and no money is available, this person even asked about, can we get safe and drug-free schools money reinstated, and another asked about drug-free community funding that might be available beyond the formal, can you just speak to the funding and the buy-in aspects of this?
Yeah, so certainly from a funding perspective, I would say that's the role of Congress. What we have seen is that generally true primary prevention funding has been flat. And so you think about the Substance Use Prevention Treatment Recovery Services Block Grant, which is a key investment to states for prevention. There's a 20% prevention set aside, but largely that's been pretty flat. And if you account for inflation, you account for other economic factors, the purchasing power of those prevention dollars is substantially lower today than it was 10 years ago. And that really is the same for our discretionary grant programs. We have a number of discretionary grant programs at SAMHSA. Our SPIF Partnership for Success program is one of our largest prevention investments. But again, it's been relatively flat funded. So we in the communities and states that we're funding are increasingly able to do less with the dollars that we have. So I think there is an urgent need to think about how we get additional resources to address this prevention challenge, because to me, prevention is the long run strategy here, right? We need to do all of the things to stop overdose deaths, but we also need to look at these upstream factors of why people are using substances in the first place. And if we don't make those investments, we're going to be playing catch up, and we may not be able to catch up, certainly as quickly as we would want. So I think there is an opportunity to help people articulate what prevention is, to make it tangible for what that means in your community. I have talked to many people on the Hill and others outside of the field who really don't know what prevention is. Again, I think many people put it in a box. It's a program that's done in high school. Clearly, that is not what prevention is. But we have to do a better job. I have to do a better job of being able to say, this is what prevention looks like in your community. This is why it's important. This is why there's a value to you and your community for making this investment. I think that partially answers the question about how do we get buy-in, right? We have to make it tangible for people. We have to help schools understand that if you're worried about the mental health challenges that are playing out among your students, if you're worried about students overdosing and dying, if you're worried about other risk behaviors, delinquency, people not graduating, you can tack that all back to substance use risk and protective factors, and the fact that substance use prevention can benefit all of those things, right? It's not just about reducing substances. It's looking at how are we setting kids up for success. And to me, that is what substance use prevention does. But you have to make it tangible for people. You have to see where is the benefit for them. I think for schools, a clear-cut case. But schools are also very busy. They're being asked to do a lot. So we have to think about what is that community connection to schools? How are we working with PTAs? How are we working with local coalitions in communities to say we can provide and engage to help support you schools in doing this work?
Beautifully answered. Thank you, Captain Jones. I've actually got a million questions that I do not have time to ask you right now. You are very popular. What you are saying is very popular. It's resonating with the audience out there. And what I would advise you all to do is we will be uploading his presentation. Actually, it's already available to you now. You can download it from your resource button there and access the resource supplement and Captain Jones, I just want to personally thank you on behalf of the entire ADAPT team for joining us. I know you've been transitioning into this new role, and this was a kind of a critical time period for you, but the messages that you are leaving us with are ones that we won't forget. Thank you for that.
Great. Thank you so much.
At this time, we are going to transition to break, and we will see all of you at 10:30 Eastern, back for our next session, which will be offering a global perspective on prevention and youth with a member of the United Nations Office of Drugs and Crime, Dr. Wadi Malouf. So we will see you there.